Okay. Okay.
Sir, we are in live, sir.
Sir, we are in live. Sir, we are in live.
Okay. Assalamu alaikum. I am Dr. Mohd Abu Shaheen. Welcome to you all to today's webinar on Sjogren Syndrome. This webinar is organized by the Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University, using the platform of BD Physicians. Today, we are very, very happy that the Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, Professor Dr. Mohammad Sharfuddin Ahmed, joined with us as the chief guest. We feel honored that Pro Vice Chancellor Academic, Bangabandhu Sheikh Mujib Medical University, Professor A.K.M. Musharraf Hussain also linked with us as the special guest. This program is chaired by Professor Minhaj Rahim Choudhury, is the Chairman, Department of Rheumatology, BSMMU. We are delighted that Professor Soyed Atikul Haq, legendary rheumatologist and President Appler, Professor J.J. Raskar, our old friend, great rheumatologist, Professor Emeritus of the Netherlands, Professor Muhammad Nazrul Islam, Professor of Rheumatology, BSMMU, Dr. Masudul Hassan, rheumatologist, joined with us as panel of experts. Today, we have two speakers, Dr. Muhammad Rahiduzzaman Sajjad and Dr. Shoaib Momen Mojumdar, rheumatologist, BSMMU. Dear participants, we have time slot for question and answer at the end of the speeches. Please drop your questions in the chat box. Now, with the kind permission of the chairman, Professor Minhaj Rahim Choudhury, now I like to request our first speaker, Dr. Rahiduzzaman Sajjad, to deliver his speech. Please, Dr. Rahiduzzaman Sajjad.
Thank you. আমি কি স্ক্রিন শেয়ার করতে পারবো?
Please share your screen.
Okay. দেখা যায়?
Yes, you are visible and audible also.
Okay. Honorable Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, Professor Dr. Sharfuddin Ahmed, Honorable Pro Vice Chancellor, Professor A.K.M. Musharraf Hussain, distinguished guest from abroad, Professor Hans Raskar, the special teachers and learned audience. My today's topic is Sjogren Syndrome, clinical feature and diagnosis. The topic of discussion would be like this. Introduction: Sjogren Syndrome is a chronic inflammatory disease. It affects mainly lacrimal gland and salivary gland, and that causes dysfunction of that glands. It may be primary or secondary form. The median age of onset is around 50 to 60 years. Regarding the discovery of this disease, in 1892, Johann von Mikulicz was the first to describe a patient with enlargement of parotid and lacrimal glands. In 1933, Heinrich Sjogren was the first to describe 19 female with clinical and pathological manifestations of Sjogren syndrome. In 1951, Sjogren published a paper describing 80 patients with keratoconjunctivitis sicca associated with Sjogren syndrome. In 1976, the first symposium on Sjogren syndrome was held in Sweden. The overall incidence of Sjogren syndrome approximately 7 per 100,000 person per year, and prevalence rates in other population registries was 0.01 to 0.09%. In an international multi-center registry, the ratio of women to men was highest in Asian, that was 27:1, and lowest in Black or African American, that was 7:1. The prevalence of secondary Sjogren's in rheumatoid arthritis was 17.1%. Systemic lupus erythematosus was 8 to 20%, and systemic sclerosis 14% respectively. Here is a picture. I think everybody knows her. She is Venus Williams. And after 6 years of swollen joint fatigue and dryness of mouth and eye, she was diagnosed as a case of Sjogren syndrome in 2011. And she has the victories of 49 singles with this disease and also 7 Grand Slams. Types of Sjogren syndrome, it may be primary when there is no association with other connective tissue or other disease conditions. And it may be secondary when uh, the primary disease remains behind causing Sjogren syndrome. It may be chronic inflammatory joint disease like rheumatoid arthritis, other connective tissue disorders like systemic lupus erythematosus, mixed connective tissue disease, systemic sclerosis, and autoimmune myositis. And organ-specific autoimmune disorders, that is uh, autoimmune hepatitis, primary biliary cirrhosis, multiple sclerosis, and myasthenia gravis. Now, the pathogenesis of Sjogren syndrome. The actual etiology is unknown. Multiple factors may cause the disease activation, that is genetic, epigenetic factors, environmental factors, hormone, and psychological factors. And these factors may precipitate the disease with the activation of innate and adaptive immunity. And neuropsychological factors in the pathogenesis of Sjogren syndrome, there are studies where severe psychological stress, defective coping stress strategies, lack of social support found to be associated with primary Sjogren syndrome. Hormonal factor also found to be associated with Sjogren syndrome, uh, as because postmenopausal women are affected more. In animal model studies, it was proved also. There are some viral triggers that may precipitate the disease, that was Epstein-Barr virus, cytomegalovirus, human herpes virus type 8, human T lymphotropic virus type 1, hepatitis C virus, and enterovirus. There are genetic association of this disease. Both HLA and non-HLA genes have been associated with Sjogren syndrome. HLA-DR and HLA-DQ have the strongest association with Sjogren syndrome. A recent meta-analysis on uh, HLA class 2 alleles analyzed from 23 studies across the world, HLA DQA1, DQB1, and DRB1 allele were found to be associated with increased disease risk. And there are also a lot of non-HLA genetic factors, T cell function and signaling, B cell function and signaling, and lots of things in here. Here is the interplay of immune and non-immune factors in pathophysiology of Sjogren syndrome. Here is the environmental factor of genetically predisposed person. If there is environmental factor, there may have some change in the epithelial tissue. It could be immune mediated or might be non-immune mediated. The immune mediated factors are immune cells like dendritic cells, natural killer cell T cells and B cells, cytokines and chemokines, also antibodies play the role, and causing the autoimmune epithelialitis of glandular and extraglandular epithelium, and that causes secretory dysfunction. There is also non-immune factors, structural integrity of acinar cells and secretory apparatus that causes secretory dysfunction. And these immunopathogenic factors ultimately causes the destruction of epithelium of this salivary lacrimal gland and also other epithelial uh, sites. Now the diagnosis of Sjogren syndrome. In 2016, American College of Rheumatology and European League Against Rheumatism classification criteria for primary Sjogren syndrome. And it was published in Arthritis and Rheumatology in January 2017. Here are some items of the classification criteria. It was the objective evidence of both salivary and lacrimal glands. Labial salivary gland, item 1, labial salivary gland with focal lymphocytic cell dendritis and focus scores of more than equal to 1 foci per 4 square millimeter, and it weighs 3. NTSSA or low positivity, it also scores 3. Ocular staining score more than 5 in at least one eye. It scores 1. Sharma test less than 5 millimeter in 5 minutes. In at least one eye, it also scores 1. And unstimulated whole cerebral flow rate less than equal to zero point 0.1 milliliter per minute, and it also scores 1. And here we mentioned the focus score, and that weighted more. Focus score is defined as the number of mononuclear cell infiltrates containing at least 50 inflammatory cells in a 4 square millimeter granular section, and of greater than one uh, single most important test result in diagnosis of Sjogren syndrome. And how to utilize the ACR regular classification criteria. If it meets the inclusion criteria, does not have any condition listed as exclusion criteria, and score of more than equal to 4 when the weights from the 5 following criteria items. Now the inclusion criteria of that classification criteria, it will be applicable to any patient with at least one symptoms of ocular or oral dryness. The question is, have you had daily persistent troublesome dry eyes for more than 3 months? Do you have a recurrent sensation of sand or gravel in the eyes? Do you use tear substitutes more than 3 times a day? Have you had a daily feeling of dry mouth for more than 3 months? Do you frequently drink liquids to aid in swallowing dry food? So with these questions, we can identify if anyone answer is positive, he or she may be included in the diagnostic criteria. The exclusion criteria are history of head and neck radiation treatment, active hepatitis C infection with confirmation by PCR, AIDS, sarcoidosis, amyloidosis, graft versus host disease, and IgG4 related disease. And here is the important thing in the diagnosis of Sjogren syndrome, the by affecting the salivary gland and also lacrimal gland. So we need to evaluate clinically and also with the objective evidence of the affected gland. So these are the salivary glands along with minor salivary glands, which is very much important in diagnosis. 30 to 50% of the patients with Sjogren syndrome affect salivary gland. The glands are usually firm, diffusely enlarged, and non-tender. Changes are most obvious in the parotid glands. Salivary gland enlargement may be either chronic or episodic, with swelling followed by reaction over a few weeks. So, with the reduction of the flow of the salivary gland, there may have some clinical features with the manifestation of dry mouth, that are dysphagia, adherence of food to buccal surfaces, problems with denture, changes in taste, inability to eat dry food or to speak continuously for long periods, dental caries, oral candidiasis, gingival restriction, bacterial infection of sense duct, that is uh, laryngotracheal reflux, lead to cough, frequent throat clearing, substernal pain, nocturnal awakening, and stimulates panic attacks, and chronic epiphysitis, weight loss, and nocturia. And before taking it as a criteria, we must exclude something as dry mouth. We have to take the history of drugs, that is antidepressants, antihistamine, anticholinergic, diuretics, and neuroleptics. We have to exclude some systemic disease that already mentioned earlier. We have to exclude also psychogenic causes of anxiety and also radiation therapy and dehydration. If we examine the mouth oral cavity, we may found the tongue like this, dry, rough, and may have some furrow, and with the lots of dental caries inside the oral cavity. So to fulfill the criteria, we need to have some objective evidence. And here is the unstimulated whole saliva collection. And patient draws passively into the collection tube for 5 minutes, and it scores 1. And how to calculate the salivary flow rate? It would be post-wet measure minus pre-wet measure divided by collection period. And if it is less than 0.1 gram per minute, then the score will be 1. And here is another objective evidence of involvement of salivary gland. Here we can show the normal minor level salivary gland, the striated duct in the center and surrounded by mucus secreting AC9 here. And here is the patient with Sjogren syndrome. Salivary gland lobule, multiple dense lymphocytic aggregates, focal lymphocytic cyanodenatitis is here. So next, the involvement of lacrimal gland, and we can evaluate clinically and also should get the objective evidences. And if the lacrimal gland involved, we may found the features of conjunctivitis sicca or Sicca syndrome. Patient may complain of light sensitivity, red eye, burning sensations, VT sensation, generalization, blurred vision, foreign body sensation, or paradoxical excessive tearing. Before taking into account of uh, dry eye, we must exclude some conditions that are advanced stage systemic disease like diabetes, Parkinson's disease, contact lens wear, systemic medications like antihistamines, anticholinergic, estrogens, isotretinoin, selective serotonin reactive antagonists, amiodarone, nicotinic acid. Ocular medications like those containing preservatives, nutritional deficiencies like vitamin A deficiency, decreased corneal sensation, ophthalmic surgery, especially corneal refractive surgery, and low humidity environment. Uh, to see the lacrimal dysfunction, the objective, one of the objective evidence that is mentioned in the classification criteria, that is Sherman test. Reflex tear protection is measured using Sherman test. A folded test strip of sterile filter paper is placed over the margin of each lower eyelid at the junction of middle and lateral third. The extent of wetting is measured over 5 minutes with the patient's eye gently closed. The test is performed without topical anesthesia to assess reflex tearing. Wetting of less than 5 millimeter without anesthesia is indicative of aqueous tear deficiency and is a classification criteria for Sjogren syndrome. The findings are typically similar in both eyes. And here is the picture of measuring the Sherman strip. Now ocular surface staining. Damage, if there is hypoperfusion, hyposecretion of lacrimal gland, there will be damage of epithelial cells of both cornea and conjunctiva. And these are the objective evidence of uh, damaged corneal and conjunctival epithelial cells. And dyes are used here, fluorescent dye to stain the cornea and lissamine green to stain the conjunctiva. To use the fluorescent and lissamine green dyes, sequential examinations are required. First, fluorescent is instilled. The both tear breakup time and corneal staining are assessed with a slit lamp with a covered blue filter in a period of less than 4 minutes. Second, a drop of 1% lissamine green dye is instilled in each anesthetized eye. Excess dye is whipped away and the eyes are then observed immediately with a slit lamp. And here is the fluorescent staining and stain the cornea, and lissamine green stain, it stains the conjunctiva. And how to calculate? Sjogren International Collaborative Alliance of Ocular Staining Score form. Here the staining pattern Lyseman green staining, it stain the conjunctiva only and fluorescent cornea only. And grade is 0 to 3. And we have to count the dots. If the dots more than 100, then Lyseman green staining score will be 3. In fluorescent staining, if the dots more than 30, the score grade will be 3. So uh, uh, there will be 3 plus 3 in each eye for the staining, and additional 1 plus would be added if there is patches of confluent staining, if there is staining in pupillary area, and or more filamenta. And total 12 score, that is 12 grade is in each eye. Antibodies to Rho and La, that is anti-SSA and anti-SSB. Primary Sjogren syndrome often possesses antibodies to the Rho and La antigens. The frequency found 60 to 80% in primary Sjogren syndrome exhibits one or both of these autoantibodies. A panel of antibodies tests for use of diagnosis in early Sjogren syndrome is being marketed that includes the test of antibodies to murine parotid tissue proteins, that that is parotid secretory protein, carbonic anhydrase 6, and salivary protein. But these biomarkers are not validated still to establish the diagnosis of early Sjogren syndrome. So we should be dependent on anti-SSA and anti-SSB measurement. So what I have told earlier, according to the classification criteria of primary Sjogren syndrome in 2016, and here is about the classification criteria of secondary Sjogren syndrome. In 2002, secondary Sjogren syndrome criteria was mentioned, but later in 2016 it was not mentioned. So here is a review paper uh, that was published in Pneumatologia 2019. Classification criteria for secondary Sjogren syndrome, current state of knowledge. According to redefined 2002 Sjogren syndrome classification criteria, diagnosis of secondary Sjogren can be made with coexisting connective tissue disease, presence of ocular or oral symptoms, and positive results of Shamas test or Rose Bengal staining. Focus score more than equal to 1 in histopathological examination of minor salivary gland or involvement of salivary glands confirmed with scintigraphy, salivography, or unstimulated salivary gland. In primary Sjogren syndrome, focus score and unstimulated salivary flow was mentioned, but uh, uh, salivary gland scintigraphy and salivography was not mentioned here. It was agreed that antibodies specific to SSA and SSB antigen cannot be considered as a marker for secondary Sjogren syndrome. So there is no importance of antibody in the diagnosis of secondary Sjogren syndrome. And now the other organ involvement. There is some constitution features, that is fatigue in 70 to 80% cases, negative impact on their quality of life, sleep disorders, anxiety, depression, chronic or discrete pain, fibromyalgia, low-grade fever, and fever with low night sweats. And many organ may be involved in both primary and secondary Sjogren syndrome. Uh, uh, as there is destruction of epithelial cells, so there may have many cutaneous manifestations and manifestations in the organ where there is epithelial lining. So in cutaneous manifestation, there may have purpura, vasculitis, annular erythema. Gynecological manifestation may be ovulatory dysfunction, dyspareunia, adverse pregnancy outcome, and vaginal dryness. May have musculoskeletal symptoms, and also neurological symptoms, central nervous system, autonomic nervous system, and peripheral neuropathy also. Pulmonary involvement may occur here along with renal involvement. The pulmonary manifestations of Sjogren syndrome. Uh, uh, this box is taken from European Respiratory Review 2016. Airway disease are cough in 41 to 61% cases, bronchial responsiveness in 42 to 60% cases, bronchiolitis of 12 to 24%, and especially in Sjogren syndrome, it is mainly follicular bronchiolitis, and bronchiectasis in 7 to 54% cases, and mainly cylindrical bronchiectasis. Pulmonary infections also found in 10 to 35% cases. Interstitial lung disease found here. NSIP is found 45% cases. Usual interstitial pneumonia 16%, lymphocytic interstitial pneumonia 15%, and organizing pneumonia in 11%. Other pulmonary manifestations in Sjogren could be pulmonary amyloidosis, pulmonary lymphoma, and pulmonary embolism also. The renal manifestations of Sjogren syndrome is distal renal tubular acidosis, nephrogenic diabetes insipidus, hypokalemia without renal tubular acidosis, membranoproliferative glomerulonephritis and membranous glomerulonephritis, minimal change disease, immunoglobulin IgA nephropathy, and associated vasculitis. So, to see the extent of disease and uh, to exclude the other conditions, we need to do many other investigations. And serological and other laboratory testings are CBC, ESR, and CRP, urinalysis. Uh, there may be glomerulonephritis, features of the glomerulonephritis in the form of red cell cast and proteinuria, or interstitial nephritis or renal tubular acidosis, that is mild proteinuria. Urine pH may be more than 7 in the face of metabolic acidosis. AGPT, creatinine, TSH, thyroid antibodies, test HCT, HSCT of test, MRI, NCS, EMG, uh, to, uh, to see that primary disease that causes secondary Sjogren syndrome. And other antibodies may need to be detected, that is ANA, anti-DNA, rheumatoid factor, anti-CCP antibody, anti-centimere antibody, anti-HCl70, muscle enzymes like CPK, LDAs, and DOLAs, etc. Investigations to exclude other diagnoses. That was uh, uh, that was mentioned to exclude the criteria of primary Sjogren syndrome. Anti-HCV to be confirmed by PCR, anti-HIV, lymph node biopsy, histopathology, other tissue biopsy, and histopathology, bone marrow study. And here is some investigations that is very much helpful in diagnosis in confusing cases. Here is the ultrasonography of parotid gland in a patient with Sjogren syndrome, and there is that correlates with the histopathological findings. Here we can show the numerous hypoechoic rounded area, some of which bounded by hypoechoic area bounded by hyperechoic area, and also uh, punctured area of calcification. And it strongly correlates with the core biopsy of the parotid gland, and it means there is lymphocytic infiltration of the gland. And we can do the MRI to evaluate the enlarged parotid glands, whether it is Sjogren syndrome or not. In T1 axial image, multiple punctured low signal foci are present diffusely throughout the both parotid glands. In T2 stair image, the same foci have high signal intensity. An inhomogeneous fine or post-nodular parenchyma is characteristic of involvement of parotid gland in Sjogren syndrome. So MRI may give us clue in diagnosis of Sjogren syndrome. And complication, Sjogren's comes with serious complication if left untreated, including increased risk of lymphoma and multiple myeloma, oral yeast infection, dental cavities, vision problem, inflammation leading to bronchitis, pneumonia, and other lung problems, kidney function problems, autoimmune hepatitis or cirrhosis of liver, giving birth to a baby with heart problems, that is, if it is patients with lupus, peripheral neuropathy, interstitial cystitis, or bladder. And now the take-home message. Sjogren syndrome should be suspected in individuals with persistent symptoms of dry eyes and or mouth, carotid gland enlargement, and unexplained increase in dental caries. Before considering the diagnosis of Sjogren syndrome, one should exclude the other causes of dryness of mouth and eyes from history and clinical examination. Objective evidences are more worthful in diagnosing Sjogren syndrome. High index of suspicion for Sjogren syndrome is important in dealing with autoimmune pancreatitis diseases. Collaboration and teamwork is required among rheumatologists, ophthalmologists, dental surgeon, pathologist, ENT surgeon in diagnosis and treatment of Sjogren syndrome. And before conclusion, I want to share a sweet memory with our Honorable Vice Chancellor and also our respected teachers, where I received the Young Researcher Award from Lopez Foundation of Bangladesh. And thank you. Thank you for your precious hearing.
Thank you. Thank you, Dr. Rahiduzzaman Sajjad, for your nice presentation.
May I stop sharing? Okay.
Yes, you can stop your sharing. Dear participant, lot many question already in the Dropbox from more than 27. We have two attractive gift for best two question. I like to request Professor J.J. Raskar, please have a look on the in the chat box and question and answer box, and please try to. You are our most important foreign delegate today. So our chairman requesting you to select best two questions for today's session. Now I'd like to request our second speaker, Dr. Shoaib Momen Mojumdar. Please share your screen and present your topic.
Thank you, sir, for giving me the opportunity to talk on this August session. Honorable Vice Chancellor, Honorable Pro Vice Chancellor, respected Raskar sir, dear teachers and dear audience, Salam Alaikum and good evening. I am Dr. Shoaib Momen Mojumdar. We're going to talk on management of Sjogren syndrome. We know that Sjogren syndrome is a multifaceted disease, and it is grossly divided into two parts, the glandular and the extraglandular part. Now, I would like to talk on treatment of glandular manifestations. For the prevention of dryness, that means dryness of eyes and mouth, patients should be encouraged to take good hydration, like taking regular sips of water, drinking sugar-free liquids, and avoidance of oral irritants like coffee, alcohol, and tobacco, and avoidance of certain medications that have been mentioned by my previous speaker, like anticholinergic drugs and medications for urinary incontinence and depression. So the first line of treatment is non-pharmacological stimulation, who experience mild glandular dysfunction or mild dryness. And sugar-free candies, lozenges, or sugar-free chewing gums are the preferred agents for this treatment. And these are available on the online shopping store, Daraj. These patients are more prone to develop dental caries, and they should be advised to brush 2 times in a day. And these patients are advised to use the brush which contain the fluoride, like Mediplus or Sensodyne. And they should regularly clean their teeth with using the dental floss in such a way. And they should be advised to visit their dentist according to the severity 4 to 6 months, every 4 to 6 months in a year. So the pharmacological, now come to the pharmacological stimulation. It is basically are those who experience insufficient response to basic measures. And the drugs are here, the muscarinic agents like pilocarpine and severin, and mucolytic agents like N-acetylcysteine, artificial saliva, and some drugs like hydroxychloroquine and rituximab. Regarding the use of pilocarpine, it should be started in a slow way. That means once daily dose, and it can be given 5 times, 5 milligram up to 4 times in a day, and should be taken half hour before meal. And the N-acetylcysteine should be reserved only those who are intolerant and those who are non-responders to the muscarinic agents. And the dose is 600 milligram 2 times in a day. The artificial saliva is basically used whose response is poor by pharmacological or non-pharmacological interventions. The artificial saliva can aid the dysphagia while taking it before the meal, or it can also be taken before the bedtime. Now, regarding the use of systemic inflammatory drugs like hydroxychloroquine and rituximab, basically the evidence is very weak here, but they provide some benefit for the sicker symptoms when they are used for the severe systemic manifestations. Now, the treatment of other sicker symptoms like the dry skin. So the patients should be advised to avoid the traditional soaps. The synthetic cleansers like Dove soap are preferred. Regular use of moisturizing agents like glycerin or topical urea like Equida can be used. In refractory cases, prednisone 50 milligram per day for 2 months or can be given. And in severe cases, primary biliary cirrhosis should be searched. Now the treatment regarding the dry eye. And basically this part is concerned with the ophthalmologists. And we know that our Vice Chancellor Shorpuddin and Professor Shorpuddin sir is with us. And we know that he is a very good ophthalmologist. And this part should be treated in collaboration with the ophthalmologists. The patient should be educated for the avoidance of dry, windy, and outdoor environment, dry indoor environments, and areas with polluted air or irritants, including the presence of smokers. And prolonged computer use may also aggravate the symptom. And we know that we should avoid some certain medications like antidepressants, antihistamines, anticholinergics, diuretics. Those who suffer from coexistent depression, citalopram or fluoxetine can be used because these drugs have low anticholinergic potential. So for the initial treatment of mild ocular dryness, when the patients wish to travel in a dry or windy environment, they should be advised to use the wrap-around sunglasses. We see that the side are quite large, like side shields. All patients should be advised to use the artificial tears like hypromellulose or carboxycellulose. And it can be used every 2 to 4 hours interval. And it is preferred to use the preservative-free artificial tears should be used. I don't know whether these are available in our country, preservative-free artificial tear. I think that Professor Shorpuddin sir can answer in this regard. Patients should be educated that they should not instill artificial tears as often as possible. Topical cyclosporine should be used those who have a poor response despite regular use of artificial tears. The initial dose is low as 1 drop 12 hourly, and it can be used simultaneously with artificial tears. Initially, they may cause burning symptoms, which can be mitigated by using using topical glucocorticoid, which should be done in consultation with an ophthalmologist. In severe ocular dryness, the dose of topical cyclosporine can be escalated up to 4 times in a day. Topical steroids can be used, permanent punctal occlusion, and as I previously mentioned, that hydroxychloroquine and rituximab can be helpful on the background of systemic, when they are basically used for systemic active disease. Now the extraglandular diseases. We know that it is a multi-system disease because going to the regarding the extraglandular diseases, there are it's better. I want to share some the severe and potentially life-threatening manifestation because we basically will talk on these issues. The severe life-threatening systemic manifestation of Sjogren syndrome, we can divide into several domains like cutaneous manifestations like diffuse vasculitis with ulceration, pulmonary domain, ILD with NIHA 3 or 4, the renal domain, renal failure, rapidly progressive glomerulonephritis, hypokalemic periodic paralysis. The peripheral nervous system domain, neuropathy, including the ganglionopathies, polyradiculopathies with severe motor deficit or ataxia. The CNS domain, like demyelinating disease, cerebral vasculitis, or transverse myelitis. Severe in case of hematological domain, severe hemolytic anemia or severe autoimmune thrombocytopenia. And in muscular domain, muscular involvement with severe weakness. So these conditions should be treated aggressively. So now come to the fatigue treatment. There are multifactorial causes of fatigue in Sjogren syndrome, but it mostly occurs due to Sjogren syndrome itself. So the first line of treatment is low impact aerobic exercise, which I have shown in the right side of the slide that these are the low impact aerobic exercises. The second line treatment is hydroxychloroquine, and the third line treatment is a 2-week course of 15 milligram prednisolone. And conventional synthetic disease-modifying drugs and rituximab can be used in case of refractory fatigue. The articular manifestations, which is most commonly we encounter, so it can divide into two parts, the arthritis part. Those who have joint count less than 5 and more than 5. If the joint count is less than 5, the first line of treatment is NSAID along with hydroxychloroquine. Those who have joint count more than 5, the hydroxychloroquine should be combined with glucocorticoid at the dose of 0.5 milligram per kg per day. And the second line treatment, or those who have poor response or inadequate response to glucocorticoid, oral immunomodulatory drugs like methotrexate, leftomide, or azathioprine can be added. And for refractory cases, rituximab and abatacept can be added or can be used. For cutaneous vasculitis, it can divide into two parts, into the mild and severe vasculitis. Those who have mild, flat, petechial, or small purpuric lesions, the patient should be advised on initially non-pharmacological management like compression stocking, avoidance of prolonged standing. And for pharmacological treatment, hydroxychloroquine and colchicine 0.6 milligram 2 times in a day are preferred agents. And those who are refractory to these drugs, prednisolone 15 to 30 milligram for 2 to 3 weeks can be given. And for refractory mild cutaneous vasculitis, methotrexate, leftomide, azathioprine, rituximab, and longer courses of prednisolone can be given. In case of severe cutaneous ulceration or digital necrosis, high-dose glucocorticoid or IV pass methylprednisolone, plasma exchange, cyclophosphamide, or rituximab 1 gram every 15 days interval can be given. Now the pulmonary movement, which is also concerned with our Honorable Pro-Vice Chancellor Moshorat Hossain sir. And we see that here that in case of one of the common manifestation that has also been mentioned by my previous speaker, that is ILD. And we know that the 4 types of ILD occur here. The non-specific interstitial pneumonia, NICP, usual interstitial pneumonia, UIP, lymphocyte interstitial pneumonia, LIP, and organizing pneumonia. So for all the types of interstitial lung disease, the cornerstone of treatment or drug is prednisolone. But there is a difference of the dose of the prednisolone in the different types of interstitial pneumonia, interstitial lung disease. So it's better to confirm the specific diagnosis of interstitial lung disease, for we can determine the actual dose of prednisolone in these cases. For the non-specific interstitial pneumonia, we know that it is predominantly present as groundless opacity. The dose of prednisolone is 0.5 to 1 milligram per kg body weight, and it should be ideal body weight. And we see that on the right side corner that there is a formula for getting an ideal body weight, how to get out. if a person having actual body weight is 72 kg, using this formula, we get the ideal body weight is 61 kg. So in these cases, if we use 1 milligram per kg prednisolone, the dose should not exceed 60 milligram daily. Besides prednisolone, azathioprine and microphenolate can also be used, and for refractory diseases, rituximab, cyclophosphamide, or cyclosporine can be used. And in case of usual interstitial pneumonia, we know that they usually present with honeycombing appearance predominantly. And those who have a poor response, or those who progressive fibrosing ILD despite the previously mentioned treatment, nintedanib or pirfenidone can be used in these cases. In case of leukocytic interstitial pneumonia, the dose of prednisolone is lower than that of NSAID, and it is 0.25 to 0.5 milligram per kg ideal body weight. And every patient who are on prednisolone more than 20 milligram per day should be put on pneumocystis jirovecii prophylaxis, like protamoxazole. Here we see the radiological picture that is there. In case of LIP, they present with multiple cavitary lesions, and those who are refractory to initial prednisolone, azathioprine, cyclophosphamide, cyclosporine, or rituximab can be used. In case of pneumogenic organizing pneumonia, this may be created often with confusion with the community-acquired pneumonia, as they present with consolidation. But here you see that the consolidation may be bilateral or usually bilateral. And here the dose of prednisolone is a bit higher. It is 0.75 to 1 milligram per kg body weight, ideal body weight. And those who fail to respond to prednisolone, cyclophosphamide, cyclosporine, and rituximab can be used for refractory cases. And for pulmonary hypertension, that it is similar to other connective tissue associated pulmonary hypertension, and the preferred treatment is imbrisartan plus or with tadalafil. And the renal improvement, we know that basically the involvement occurs in two ways. One is interstitial nephritis and another is glomerular disease. And this has been mentioned by previous speaker. So I will basically talk about the distal renal tubular acidosis and hypokalemia. We have seen many cases or some cases in our ward that some patients presented with recurrent hypokalemic periodic paralysis was eventually diagnosed, and as a case of type 1 renal tubular acidosis, and finally for finding to have the case that we found some of the cases belong to Sjogren syndrome, some of the cases belong to SCD. So we know that in case of renal tubular acidosis, type 1 renal tubular acidosis occurs due to impaired hydrogen ion secretion in the distal renal tubule, and they present frequently with hypokalemia, and the unit pH is more than 5.5 here, and they present with also nephrocalcinosis. So basically the first line treatment is, one of the first line treatment is alkali therapy, and one of the important component is potassium citrate and citric acid combination. And these are available in the market, and each 5 ml, that is 1 spoon TSF contain 10 milliequivalent of potassium, which delivers the equivalent dose of 10 milliequivalent dose of bicarbonate. So those who present with severe metabolic alkalosis, like serum bicarbonate less than 16 milliequivalent per liter, the dose is 30, that is 3 TSF, 30 milliequivalent of bicarbonate or citrate 4 times in a day. That is 120 milliequivalent dose per day. And if the sodium bicarbonate is more than 16, that is mild metabolic acidosis, the dose is much lower, 40. That means 4 TSF, 40 milliequivalent of potassium bicarbonate or citrate 2 times in a day. That means 80 milliequivalent dose per day totally. Those who have severe and symptomatic hypokalemia, like the potassium is less than 2.5 millimole, or severe weakness or cardiac arrhythmia, this patient should be treated with, preferably treated with IV potassium chloride, and it should be started at least concomitantly or prior to the initiation of alkali therapy. besides the treatment of alkali and potassium supplementation, and these patients should be also treated with steroid and immunosuppressive treatment for the treatment of tuberculosis. The dose of prednisolone here is 0.5 to 1 milligram per kg per day, ideal body weight, and hydroxychloroquine or azathioprine or mycophenolate mofetil should be supplemented or added with prednisolone. Now the neurological manifestations. There are many neurological manifestations. I'm not going to talk about the issue, all these issues for time constraint. I'll talk some of them. One is axonal sensory and sensory motor neuropathy, and usually present with digital paresthesia. And if we examine that, we may get that there is impairment of light touch and proprioception or vibrissations impairment. And these patients are usually treated with those who have predominant sensory symptoms. They are usually treated with gabapentin, pregabalin, or duloxetine. And those who have sensory motor polyneuropathy and those who have an inadequate response to this symptomatic treatment, prednisolone at a dose of 0.5 to 1 milligram per kg per day and along with azathioprine should be started. And those who have vasculitic neuropathy, the dose of prednisolone is higher, 1 milligram per kg per day with either rituximab or cyclophosphamide should be added. In case of small fiber neuropathy, how to realize this? Usually they present as painful sensory neuropathy. That means the patient may complain of burning or shock-like or pricky sensation in the limbs. And if we examine them, we'll get the loss of quick and temperature sensation will be lost. And the treatment is basically gabapentin and pregabalin. And venlafaxine can also be used. Here we see that the dose prednisolone and rituximab is ineffective. IVIG can be used for severe or refractory cases. So we see that the clinical distinguishing between small fiber neuropathy and axonal sensory neuropathy is very important because if there is small fiber neuropathy, prednisolone and immunosuppressive drugs are not helpful. These are ineffective here. So using these drugs will cause rather harm for the patient here. So those who present with multiple mononeuropathy or mononeuritis multiplex. So in case we have severe mononeuritis multiplex, the dose is 1000 milligram methylprednisolone followed by oral daily prednisolone. But those who present with less severe disease, the dose is prednisolone is lower. It's 1 milligram per kg per day, which should be combined with cyclophosphamide or rituximab. Now the central nervous system disorders, and usually again one of the manifestations of optic neuritis along that is one of the ophthalmological presentation is here is the optic neuritis, and this demyelination or neurological inflammation is present also with T-Wambs malaitis, which is associated with antibodies to aquaporin 4, and T-Wambs malaitis and attack of bilateral optic neuritis also occur. And in case the treatment is, if the present with acute attack of demyelination, that is here we see that in the MRI there is plaques of demyelination extending from the lower part of the brainstem and up to the fourth cervical vertebrae. So in case of acute attacks of demyelination, the preferred treatment is IV pulse methylprednisolone, which should be given for 3 to 5 days, and plasmapheresis, those who have a poor response to the glucocorticoid. And for remission induction, the patient can be put on rituximab 1 gram every 15 days interval, and mycophenolate mofetil, azathioprine, or eculizumab can be used. For hemolytic anemia, for hematological manifestations, which we know that there are 3 ways of presentation. One is neutropenia, ITP thrombocytopenia, immune thrombocytopenia, or hemolytic anemia. In case of absolute neutrophil count, if it is less than 500, we should consider granulocyte coronary stimulating factor GCSF like filgrastim. And if the response is poor, or if the platelet count is less than 20,000, the patient should be put on glucocorticoid prednisolone 0.5 to 1 milligram per kg per ideal body weight. And in case of hemolytic anemia, the same dose is applicable if it is 8 to 10. If it is less than 10, the patient, and it should be supplemented by bisesh glucose, it should be supplemented by either IVIG or rituximab, or in case of rescue therapy, plasma exchange or cyclophosphamide. So what to do in case of Sjogren syndrome with pregnancy? Those who are Rho positive, the patient should undergo routine Doppler fetal echocardiography. And this monitoring should be started from the 18th week, and it should be continued up to the 16th week of pregnancy. And if anybody having their first degree heart block is identified, the neonatal, because why this monitoring should be done? Because those who have Rho positive mother, their neonate have more prone to develop heart block, neonatal heart block, and complete heart block and secondary heart block may result in fetal bradycardia. And those who have first degree heart block, the patient should be put on fluorinated glucocorticoid like oral dexamethasone 4 milligram per day. And this should be continued. If the response is good, it should be continued up to 26 weeks of gestation. In case of second degree heart block, that means there is progressive prolongation of the PR interval. So in case of second degree heart block, it should be the dose is same, 4 milligram dexamethasone per day. And if improves, that is reversed to normal sinus rhythm, the dose can be reduced to 2 milligram, and it should be continued till the end of pregnancy. And in case of complete heart block, basically there is no treatment for the complete heart block, and most of the child after the delivery may require permanent pacing in their some course of life. But if the patient with endocardial fibroelastosis, or if the patient presents with hydrocephalus or poor LV function, besides dexamethasone or fluorinated glucocorticoid, IVIG should be used, and plasma exchange can also be considered. And all Rho positive patients who are pregnant should be put on hydroxychloroquine for the primary prevention of neonatal heart block. There are some queries regarding that about the use of kinase inhibitor. There is a clinical trial ongoing in the USA, and on the safety of tofacitinib in primary Sjogren syndrome, and this trial will conclude in 2023. So we don't know about the results of this trial yet. So up to this, I would to conclude my talk on the management of Sjogren syndrome. Thank you everybody for patient hearing.
Thank you, Dr. Shoaib Momen Mojumdar, for your brilliant lecture. Actually, I have observed both the two speakers, directly or indirectly, has thrown few questions to our honorable chief guest and special guest. I don't know whether it is how much either justified or not. So this is time for question and answer. Due to time constraint, I am advised to allow only 4 questions. I have selected 2 questions randomly, and another 2 questions, Professor Raskar. You know, he is a critical reader. He is a peer reviewer of many index journals. So this is a very simple task for him. And the Raskar will declare 2 best questions. Before that, I am asking 2 questions, one for each speaker. First speaker, my question is, can Sjogren syndrome occur in children? As well as another question to same first speaker is, TTP and Sjogren syndrome can occur simultaneously, and how severe that is? Please, Dr. Rahiduzzaman.
Yes, the first question is Sjogren syndrome occur in children? Yes, Sjogren syndrome may occur in children also, but manifestations are a bit different, and musculoskeletal manifestation is higher in that cases. Second question is TTP and Sjogren syndrome. Okay, TTP may occur in any autoimmune conditions, and this is severe manifestation. And in rare instances, TTP and Sjogren syndrome may occur, and this is very much serious condition and serious consequences. Few reports are there. There may occur both at a time. Okay, thank you.
Just one supplement for this question regarding children. In children, we can say it may occur, but definitely it is uncommon to rare. And usual age of onset is 40 to 60 years. That has to be remembered. Rarely it may be there, but we have to remember genetic and environmental factor is responsible for the causation of the disease. Thank you.
Thank you, sir. But in case of children, unexplained rash on the skin, fatigue are more common than adult. Sir, next question to our second speaker. You have mentioned water for dry mouth, repeated intake of sips of water. How much water should be taken for dry mouth? Is there any guideline or any, how should we advise our patient?
I have become surprised. So many questions, 75 questions. It is unbelievable. And so many difficult questions too. Okay, thank you. I'm feeling very much excited.
Basically, I didn't get the amount actual requirement or requisite for the water. But it is written that whenever the patient feels dry or frequent sips of water, that means the patient should not take gallons of water. That means frequent sips of water as long as the patient need to quench their thirst. So I think that it is not specifically mentioned. I think that Professor Atik sir or Rasta sir can answer if there is any specific amount in this regard or not.
Okay. Okay. Thank you. Atik sir, can you would you like to add something?
Thank you very much. I think, actually there is nothing in the literature and guidelines, but we would say that, one should not exceed an upper limit. For example, one should not subject himself to water intoxication or dilution and hyponatremia like these things. So, or also sometimes secondary compulsive polydipsia may also occur because of drinking excess water. So it is better to restrict fluid intake to 4 liters a day. The maximum intake should be 4 liters.
But
Or 5. Okay, 4 to 5.
Shaheen, I have to leave, Shaheen. So please give me a time and I will speak, and then I will leave and you will continue.
Okay, sir. So this is the time for you, and your and this is the most attractive part of our today's seminar. Speech by our chief guest, Professor Sharfuddin Ahmed sir. He is the most dynamic and hardworking Vice Chancellor, Bangabandhu Sheikh Mujib Medical University we have ever seen. But he marched only a couple of months, and in this short period, he has opened many special windows for the better future of the university. The Honorable Vice Chancellor, Professor Sharfuddin Ahmed sir, has a special interest on research. I would like to mention one thing. In the last month, maximum research projects submitted in the Health Ministry from BSMMU. And that was certainly due to inspiration of Honorable Vice Chancellor, Professor Sharfuddin Ahmed sir. He is giving his best effort and dedication by providing all sorts of support to attain the goal. We are expecting the university will be comparable to any of the best universities in the world within a period of time, short period of time. Now I'd like to request Professor Sharfuddin Ahmed sir for your valuable speech. Thank you, sir.
Thank you, Dr. Abu Shaheen. I respected chairperson of this webinar, that is Sjogren Syndrome and Update, Professor Minhaj Rahim Chaudhry, your APLAR President, Professor Syed Atikul Haq, Professor Reskar, Professor Nazrul Islam, my colleague, Professor A.K. Musharraf Hussain, Pro-Vice Chancellor, Rahiduzzaman and Shoaib, today's speaker, and all the respected panelists, and about 172 participants were there, I have seen. And before this, I was also in another webinar on stress management, where I got about 120 attendance. So the attendance is here much more, as because the topic is very much interesting to all the residents, and also it is very complicated for the patient and also for the physician. I think this disease is sometimes we think that thyroid is for ENT or thyroid for general surgery. In this way, Sjogren is ours or it is of rheumatology department. Sometimes there may be a debate, but I think it is not only of ophthalmology, it is not only of rheumatology, it is a multi-disciplinary disease, as because it is not only ophthalmic. All the exocrine gland where there, this chronic inflammatory disease, it causes everywhere. Dermatology is the largest organ of the body. Everywhere you see, that can be involved. Kidney can be involved, can be vagina can be involved. That is gynecological problem is also there, and also your rheumatoid arthritis, the joints, the spines, and everywhere it is affected. And you see autoimmune diseases like multiple sclerosis, SLE, and also systemic sclerosis, rheumatoid arthritis, everything is also involved here. I have many patients. Sometimes we think whether it is Sjogren or the drug reaction. Sometimes the patients are being, there is some DD, and we also get some dry eye. But you see, in chronic inflammatory disease, we get the some glandular dysfunction in conjunctiva, in the salivary gland, also in the lacrimal gland. Sometimes there are the parotid gland. Everywhere there is that involvement. In eye, you have mentioned many things about the staining of the cornea, about the Sharma test, and also Jones test is also being done. Some fluorescent stain and some cotton are given in the nose, and we see within 5 minutes whether it is soaked or not. That can also be tested for dryness. And you have already mentioned about the Sharma strip, fluorescent stain. Cornea is also being involved, and sometimes there is blindness, and also optic neuritis. In case of multiple sclerosis, we get many patients that there is optic neuritis. And you see, the patient may be blind due to optic neuritis. Sometimes when the corneal erosion occurs due to Sjogren, there is also some blindness. So I think this disease is very much important, and you have used, you have given many drugs like rituximab, you have given the MMF, you have given sometimes some drugs like steroid, and also some anti-inflammatory. But in my eye ocular portion, we use the artificial tear, but the drugs which are with preservative-free drugs should be used in eye, like artificial tear, some gels, some ointments, some night fresh ointments that can be given to this Sjogren patient, where the patient should not feel that he has some foreign body sensation, sandy sensation, some gritty feeling. That should not be there, and that's why we give some artificial tear and the fluid and gel also given, like tear fresh liquid gel, etc. I think the discussion, I will not say much more, as because you are the master of the Sjogren. Many of the international, Reshkar is the peer reviewer. So I hope he will also help us in research work in Bangabandhu Sheikh Mujib Medical University. I request you that you are attached to Toronto University. if you, I can invite you that you will be attached with my university for research work, and also in future, I will invite you to my university. Thank you very much for inviting me. I will not take much more time, because I have taken, still I have taken much more time. I don't want to make you bored. Thank you very much for inviting me, and I hope I will be with you in future. Thank you very much.
Thank you.
Thank you, Honorable Vice Chancellor, Professor Sharafuddin Ahmed Sir, for your brilliant and inspiring speech for us and our department. Thank you, sir.
So if you permit, I can leave Reshkar and Professor Atikul Haq and Minhaj Rahim Chaudhary. I can leave now.
Thank you very much. Thank you.
Yeah.
Okay, thank you. Thank you.
Thank you, sir.
Thank you, sir. Now I would like to request Professor Hans Raskar. Please, did you select two best question? Professor Raskar. Professor Raskar, please unmute. Please unmute your microphone.
Yeah, here we go. Sorry, I thought you unmuted me. There were many excellent questions, and some were asked twice or three times, and there are also many questions who had found their answer in the second lecture. So I would leave these out. The best question is by Dr. Mahmoudul Hassan, and he asked when to refer a patient. What are the pitfalls and drawback of diagnosis? I think it's a very important question. Apparently he comes from the general practitioner, and it's very basic which complaints are most important. I don't know whether the speaker will give a reply now, but can be perhaps later. This
question is for Dr. Shoaib. This question is for Dr. Shoaib, our second speaker.
Okay. When to refer? Can you answer that?
Yeah.
Shoaib,
yeah. It is initially, often it becomes difficult to diagnose, but whenever any patients who present with the dry eyes and dry mouth, but often in our population, the patient often doesn't complain of this dryness. We have to ask the patients about whether the patient requires frequent drinking water during their meals, or whether the patient feels any gritty sensation like this. But whenever there is unexplained hypokalemia, what we have mentioned that sometimes extracellular manifestation should be the prime manifestations of the disease, like unexplained neuropathy, or patients having ILD, or patients having recurrent hypokalemia. So in these ways, if we get, or anybody having arthritis, but symmetrical small joint involvement or arthritis, but all the autoimmune panel like rheumatoid factor, anti-CCP or ANA, these common serological parameters are negative. I think in these ways, these are the difficult cases to diagnose. So I think these are the pitfalls to diagnose a case of Sjogren syndrome, and in these patients should be referred for the diagnosis to the rheumatologist.
To the rheumatologist.
Rheumatologist.
Okay. Thank you, Professor Raskar. Next best, please. Next best.
The second question. There's a second question I have. Both are very excellent, and the first is by Dr. Shakhavat Hossain and three others. They asked, why is the risk of lymphoma increased? And I am very interested in that question, for I remember Sjogren is a very new disease. And I was so lucky to be in the beginning of the development of diagnosis and making criteria of Sjogren's. And one of the interesting papers was in New England Journal describing 7 patients with a cerebral lymphoma, and all of them had been treated for their Sjogren by azathioprine. And the conclusion was that azathioprine in severe Sjogren syndrome increases the risk of lymphoma, cerebral lymphoma, sorry. But perhaps you can answer that. I have one more question that was very interesting. So I ask a quote.
Okay.
Yep.
Okay.
Can you answer that question, perhaps? Why is the risk of lymphoma increased in Sjogren's?
Dr. Nahid, our first speaker, please.
Yeah, first speaker.
Yes. So from the pathogenesis, we come to know that there is lymphocytic infiltration of different exocrine glands and other tissues. And there is both innate and adaptive immunity comes into play. And in long-standing Sjogren syndrome, those having the positivity of autoantibodies like anti-SSA and anti-SSB with massive involvement of the glands, they are very much prone to develop the lymphomas. So here there is autoimmune process is there, and also lymphocyte implantation in the different tissues. In the long run, when there is increased lymphocyte proliferation, it may lead to development of lymphoma.
Can you comment on the cerebral lymphoma? And
usually non-Hodgkin's lymphoma is more common in case of Sjogren syndrome, but other lymphoma may occur.
May I just supplement? Just one point is important, that there are certain risk factors have been observed, like persistent salivary gland enlargement, something like that, and also those having splenomegaly, those having lymphadenopathy. This group of patients have more chance to develop a lymphoma.
Yes, very severe cases. Yeah.
Yeah. Thank you.
May I ask the second best third question is the role by Dr. Madouf Hassan, the role of sex hormones in pathogenesis. Why is this an important question? In Sjogren's is a women's disease. As far as I know, almost all women, at least in Holland, with Sjogren's have vaginal dryness. They get complaints in their marriage. I have seen several divorces due to husbands who were thinking their wives didn't like them anymore. And so this is an important question. And it's remarkable that none of us here is woman. I think we should involve gynecologists in Sjogren syndrome, and also women rheumatologists. For I know in Islamic countries, I've been seeing many patients in Egypt as a visiting professor many times, and these women's points are never mentioned, and it's a very, very important point. So this question is about the role of the sex hormones is very important.
Okay, thank you, Professor Raskar. This is end of the question and answer session. Now I am going to our respected panelists. First of all, I like to request our one of today's panel, Dr. Masudul Hassan, for a brief comment regarding presentation of both the speakers. Dr. Masudul Hassan, please.
Thank you, Abu Shaheen. Honorable Pro-Vice Chancellor, Professor Musharraf Hussain Sir, and respected Chairperson and other eminent rheumatologists. Actually, Sjogren syndrome is, we know, commonly present to us with dryness. And this dryness sometimes may be due to some other causes also. But at the extreme of the age, older, elderly people, whenever they present to us with any form of fatigueness and dryness, we should address that. And we should keep in mind that Sjogren is a very commonly missed diagnosis and underdiagnosed disease. And it is also a disease of multi-organ involvement. As we know, it involves the eye, as well as the GIT and renal systems, neurology. So we should not forget that it should not be managed by only one specialties. It should be organized, a multidisciplinary approach. And a multidisciplinary approach sometimes be very essential to treat the Sjogren syndrome. And we may then prevent the serious complications of corneal ulcerations and also interstitial lung disease and some other very serious complications of neurological involvement, renal involvements also. So with all these, our two presenters very elaborately and very nicely presented the presentation. I thank them. And I also thank you, Shaheen, for your nice inviting me in this session. Thank you very much.
Thank you, Dr. Masudul Hassan. Now I am requesting my teacher, today's panelist, Professor Dr. Muhammad Nazrul Islam sir, for his comment and suggestion, or if he likes to answer a few questions unattended, he can. Please, Nazrul Islam sir.
Thank you very much, Abu Shaheen. It's a pleasure to thank of course, today's chairperson, the chairman, Professor Minazraim Chaudhary, to organize this occasion. And I'm delighted today. In this occasion, we have the Hans Rasker. And in today's session, another beloved teacher with us, the Professor A.K.M. Musharraf Hussain, the Provisy of this university. And of course, we do have the Atiq sir with us, and Shaheen and the other fellow colleagues. There are many things our beloved students are now, they are growing very fast, and they have presented very nicely. So this is a very big chapter, I would like to say. I think now you can realize why I'm saying it's a very big chapter in the field of rheumatology, and a disease that should be addressed by multiple discipline. And interestingly, some of the key things I would like to touch is because it becomes midnight when we start at 10, or sometimes it's late even to start. So this is a disease where the CD5 expression says us some information why the subjects can develop your lymphoma. And this surface marker again helps us nowadays to track the disease course even by doing the ultrasonography. This is a disease of the all age group, but most commonly after the 40 years of age. Interestingly, the disease is more common in the female than the male. Some of the reports says the ratio is 14:1. So why to say this? As because we need to make a higher index of suspicion in the female subjects where we may miss the diagnosis. And this is the one part. And another question related to is the pitfall of diagnosis is that every chance to make the over diagnosis as well. And it's a T-cell immune mediated disease. So says us the many aspects, including the homing of the cells into the exocrine glands and of course the other parts as well. Somehow we need to keep our eyes open whilst suspecting and evaluating the cases of Sjogren, whether these are related with the common connective tissue disease, especially the rheumatoid arthritis, and some other diseases like SLE and the systemic sclerosis, and to that of the else connective tissue disease, or whether it is coming to us as a primary illness. And why to mention this one? As because if the situation is with the one other connective tissue disease, we need to take care to treat that disease as much as we can. As because once a patient develops Sjogren, this treatment becomes organ involvement, evaluation, and subsequent make a approach, something like that. Unfortunately, often the Sjogren we diagnose is very late. Once it's become too late, and then we try to with the several drugs, now clear today from our speaker, Shoaib Moment, that's because the role of the drugs, what we are using is again a issue, whether giving us benefit or not giving us benefit. We do have gray area in this field. That gray area starting from the early diagnosis, after diagnosis, treatment strategy, and especially when there is involvement of the pulmonary system. The pulmonary system involvements, why I am telling gray, is because based on the imaging findings and lung function test, we are using drugs. And unfortunately, one thing I would like to say today, for the long time, we were with the azathioprine in our many of the patients. But now papers are coming right now, a little moment ahead. Raskar mentioned use of the azathioprine and the possibilities of the CNS lymphoma. So and nowadays it is many way evident that the trust we paid on the azathioprine in treating our cases is no good. We need to think about this area again. And the gray area with the pulmonary system is that if there is a major involvement and the ground glass is there, something we can do. But once it's become honeycomb, then it becomes a problem whether the patient will get any benefit of the aggressive immunosuppressive treatment or not. So we need to think some other area, and then a patients of Sjogren demands a top to bottom checklist once with the rheumatologist to either identify or exclude the involvement of the several body system, starting from the vague complaint, fatigue, vague CNS symptom, visual disturbance, to that of the skin issues we need to keep in mind. So with this, it's my pleasure to thank you everybody and giving me the opportunity to speak on this occasion. Thank you very much, Shaheen.
Thank you, Professor Mohammad Nazrul Islam sir. Now I would like to request our honorable foreign guest panel, the great rheumatologist, emeritus professor of Netherlands, Professor J.J. Raskar. Professor Raskar, please give your valuable opinion and suggestion.
Thank you very much. I'm very impressed by both speakers of the completeness of their speeches, and I compliment the people who put the many very fascinating questions. So they proved they were very much involved in the talk and listening very intensely. I compliment you for the lead, how you have been leading the meeting, Dr. Menhai for the initiative, and yeah, I can't say much more about than I'm very glad to see how the level is how high the standards of rheumatology have become in Dhaka, and I'm glad to observe that. Thank you very much.
Thank you, Professor Raskar, for your valuable speech. Now, I'm requesting our respected teacher, our mentor, pioneer rheumatologist of Bangladesh, President Aplar and President Bangladesh Rheumatology Society, Professor Syed Atikul Haq. I am requesting Professor Atikul Haq, sir, please, sir, please.
Okay, thank you very much. I actually, respected chairman of today's webinar, dear panelist, Professor Hans Raskar, other panelists, and also speakers in the audience. I am actually amazed by the talks delivered by both Professor Dr. Nahid Sajjad and also Shoaib Momin Mojumdar. Both has covered the topic quite extensively, though in a short period of time. Their talks were quite short, interesting and engaging. I never felt bored, and I have learned from both of them. And they have given an almost complete, near total picture of Sjogren syndrome. So I think, they have done a fantastic job. And I have almost nothing to add, only that, in that chat box, I found one question that was interesting. I think that everyone should know. Someone put a question that what are the red flags in a patient with Sjogren syndrome? And I think this is important to know. It is said that, Raynaud's phenomenon is a red flag, and also positivity of all three, rheumatoid factor, NTSSA, and TSSB. If all three are present, that is also another, red flag. And in these patients, we should also do serum protein electrophoresis for identification of monoclonal gammopathy present, and also we should estimate serum C4. If there is monoclonal gammopathy and C4 is also low, then in these patients, the likelihood of development of lymphoma is greater. So in these patients, we should palpate the lymph node, and also, if necessary, we should do other tests. And also, if the patients have got refractory symptoms that are amenable to rituximab, we should consider rituximab a bit earlier than in patients without these particular red flags. That's all. I think that is only one thing that I felt the need to add, because in any case, if we miss the diagnosis of Sjogren, we won't cause great harm to the patients, because Sjogren syndrome is non-progressive or very slowly progressive in vast majority of patients. So if we miss the diagnosis for vast majority, we won't cause any harm. But the thing is that we must be aware of the red flags. That is very much important. And for that reason, I thank the questionnaire, the participant who has put this question. And thank you all. Thank you very much.
Thank you, Professor Syed Atikul Haq, sir. Now I am requesting our special guest, Professor A.K.M. Mosharraf Hossain, sir, special guest of today's webinar. Professor A.K.M. Mosharraf Hossain is a renowned pulmonologist in our country. He has a special interest on sleep disorder. He performed different activities, including seminar, lecture, and research work on sleep disorder in Bangladesh. He has also vast knowledge in the treating patients with pulmonary hypertension, DPLD, and other pulmonary disorders. Now I'd like to request Professor Mosharraf Hossain, sir, please.
Thank you, Dr. Shaheen, for your very elaborate and detailed introduction of myself, maybe that which I do not belong. And I thank organizer who have invited me to join, and our guest panelist, Professor Raskar, who is joining us. I don't know What is the time in Netherlands right now? Though it's midnight in Bangladesh. So, so we are actually having a midnight webinar, which is now the culture of Bangladesh in this COVID pandemic. I don't know what has in Netherlands. So far, I remember during my visit to Netherlands, and mostly they are very early sleeper and very early riser. So far, I remember. Anyway, so I have very little experience on the pulmonary manifestations of Sjogren syndrome, actually. And for me, Sjogren is a very orphan disease. Though I am a pulmonologist, I have encountered very few patients in my life, maybe I think 8 to 10 of patients. And so far I remember in one patient, I found that he had only pulmonary hypertension, but there was no lung involvement. And mostly the lung involvement is non-specific interstitial pneumonia. Usually interstitial pneumonia is very uncommon. And actually, when there is usual interstitial pneumonia, it's very difficult to say whether it is associated with Sjogren or it's idiopathic one. But I feel the most important one is that due to dryness of the airway, there is a recurrent chance of respiratory tract infection in this group of patients, which we must look for when we treat a case of Sjogren syndrome. Because in Sjogren syndrome, we use steroids and also other immunosuppressive therapy, which also makes the patient very much prone to develop recurrent respiratory tract infection, for which we should vaccinate the patient with all kind of available vaccination like influenza and pneumococcal vaccination. And right now we should also focus on vaccination for COVID-19 as well. So thank you everyone. And I think this is the right time to say good night, everyone. And if you permit, I can leave. Thank you very much. Assalamu alaikum.
Sir, thank you. Thank you very much. Our special guest, Professor A.K.M. Mosharraf Hossain, sir. I like to say again, this webinar is organized by the Department of Rheumatology using the platform of BD physicians. And this program is chaired by Professor Minhaj Rahim Chaudhuri, Chairman, Department of Rheumatology, BSMMU. Now I would like to request Professor Minhaj Rahim Chaudhuri, sir, to deliver his speech and conclude the today's session as well. Thank you.
Thank you, Dr. Shaheen. I'd like to request our Vice Chancellor, Professor Mosharraf, whether he has left, because I had some words for the administration really. So unfortunately, we are missing both of them. Anyway, I hope this recorded portion we will be able to.
Okay. I am.
Mosharraf sir is there. Sir, Mosharraf sir is there.
Thank you very much. Just I'll take couple of minutes. So it's it gave us a really immense pleasure that we have organized this Sjogren syndrome, and we have with us Honorable Honorable Vice Chancellor, and now still we have our Pro Vice Chancellor Academy, Professor Mosharraf Hossain. The important thing is that the patients already it has been told that many patients really first consult to an ophthalmologist and they diagnose these things, and when they feel, they refer this patient to us. And already Professor Mosharraf told that this is really to some extent uncommon involvement of the lung. That is also true. We are grateful to both our Vice Chancellor and Pro Vice Chancellor, and definitely our overseas rheumatologist expert, our great friend, Professor Hans Rasker, for attending the seminar, and as well as the other panelists. Regarding our Pro Vice Chancellor, Professor Musharraf, I remember we worked together so in early 90s, and during our training period for these kind of FCPS and MDs. And I know how academic and hardworking he is. What I would like to say, so I am taking the privileges to say a few words about our young teachers, the rheumatologists of the department, especially the 6 teachers, including today's 2 speakers. They work relentlessly for the department. They are taking classes, organizing academic sessions, seeing patients in outdoor and indoor, and helping Phase B students for their thesis work. And without this kind of hard work, it would not be possible to run the department smoothly. And they are our pride. And nowadays, rheumatology, I acknowledge and I understand, Professor Musharraf will also understand it very easily, is advancing very quickly like pulmonology. And in order to keep pace with the rest of the world, we are planning to expand our activities. And we are optimistic that we will get full support from our administration. And my thanks to our moderator. He very nicely facilitated the program. Finally, our thanks for the BD physicians, and special thanks to Dr. Ihsan. During this COVID pandemic, this platform playing a very significant role for the dissemination of the knowledge and experiences among the physicians. And with these few words, I would like to conclude my talk and to conclude this webinar too. Thank you, everybody.